we have, look here, we have an imbalance. We have imbalance, which means we have two types of population of cells. One is called osteoclast, one is called osteoblast. If you're osteoporotic,
Osteoclast more.
osteoclast more. Here we go. If I'm normal, it's basically this, right? So we have an issue here with osteoporosis. Osteoclastic activity is more than osteoblastic activity. And the osteoclasts do what? They resorb the bone. Yum, yummy. And osteoblasts, they build the bone. If we have an imbalance, I will have a bone that will look like this. The meshwork is going to be way looser, plenty of space, and fragility. It's going to be high in fragility, right? So increase in risk of, increase in the risk of fractures. Okay? So unfortunately, it is detected at the time of break, and we are already at an advanced stage. أكتر شيء, the areas where there is a high risk and it can reflect on morbidity and mortality هي بالspine وبالhip. يعني لما يصير في عندي fracture بالhip, I'm in deep trouble, and في عندي bedridden, في عندي complications, and the risk of death is going to be higher. So we're talking about serious issue here. طيب؟ هلا, to start our lecture, بعد ما بلش. To start our lecture, I have to start with something called bone remodeling. مش المودلز اللي على الكات ووك هذول اللي بيمشوا. We're not talking about this. We're talking about bone remodeling. And how does it start? شوفوا, I put a picture interesting up there. Okay? So when we plant, when we have a plant, we start by, we don't put the plant right on top of the soil, right? Just do a small hole, then put the plant, right? So this is how you're going to think about it. Osteoclastic activity, in a way, it's good. Why? Because I need to create a hole and then start building whenever there's a crack. So I found a crack on the bone because there's a continuous remodeling in the bone. That's physiological, that's normal. And in order to fix it, I have to resorb it first, then I build on it. Clear? So here we are, easy. We have the continuous physical activity that's going on with every one of us. So suppose someone is a sporty, someone holds a lot of weights, someone runs, someone falls. Some cracks will take place and happen here and there. And this is what the bone adjusts to. They do bone remodeling, okay? Now, how does it start? That a signal will recruit the bone marrow precursor, okay? It will fuse with what we call osteoclast. And that osteoclast as a cell is very interesting. First of all, it's multinucleated, more than one nucleus is there, okay? يعني لما نحكي لكم شيء اسمه pre-osteoclast, one nucleus. Then they fuse 2-3 osteoclasts, they make multinucleated osteoclast. The other thing, في عندهم ruffles. عارفين التنورة؟ شو اللي So في ruffles. هدول الruffles هيك هدول. These ruffles, they stick on the bone and they just isolate that area. There's a lot of vacuoles inside the osteoclast. There's a lot of chemicals like acids that are released, which they are which are released to resorb the bone. Okay? This is the osteoclastic activity. So the osteoclastic activity is not active at all times. We trigger the activation. We will say how. Okay? So once it is active, resorption takes place, then osteoblast will be induced and building will take place and bone lining will be formed. Easy. I want to take you on a molecular level what happens. Bear with me. This will help you to understand mechanism of action. We start with the resorption phase. فعندنا the two players. This is the bone. Hello, bone, how are you? And we have osteoblasts that are active. What they do is they create or send a signal. Signal, but how we receive the signal if we don't have the receptors? So there are receptors that are expressed on the osteoclastic cells. Look up, and the pre-osteoclastic cells, okay? Even the precursor of osteoclast, the receptors are expressed. These are called rank receptors. rank receptors يعني receptor activated and kappa B. هيك اسمه receptor activated and kappa B. These are receptors. These receptors, which are expressed on the osteoclast, the osteoblast sends a signal, okay, let's activate you, I need you. So they send something called rank ligand, rank L, and goes to the osteoclast, binds to the rank, and becomes active from pre-osteoclast to osteoclast to active osteoclast, and they start the resorption phase. Clear?
Yes.
That's resorption phase. طب معقولة إن we're gonna continue resorption بندوب بطل في عدد. Now what? في signal تاني that will go, another signal, a second signal that will be released by the osteoblast. So our maestro is the osteoblast. They send the first signal. After some time, they say, that's it, enough, you have done your job. I will stop you. How do I stop you? By releasing another. Here, before I move on, كمان ما تخافوا إذا شفتوا هاي. This is سموهم suction cups. Have you seen them? Suction cups. Okay, this is exactly the concept of osteoclast. They, with their ruffles, the skirt, they bind to an area on the bone and they suck it. خلاص, it's isolated, and then under that area they release these chemicals which resorb the bone. This is their activity. Okay? So that's why I want you to remember, when you understand the activity of osteoclast and how does it take place, this is how it. So the ruffles are needed, the chemicals are needed, and the fact that it is active osteoclast. Now, to continue, once this thing has been resorbed, then the osteoblast said, خلاص, enough. What we do, we release another chemical. It stands for OPG, but it's called osteoprotegrin, from protection. So I want to protect the bone, I release something called osteoprotegrin, okay? And what does it do? It stops the rank ligand. No more release of rank ligand. Done. Okay, so you see stop sign. So it's called osteoprotegrin. Okay? خلصنا resorption. Now what? Now we do the osteoid formation. خلص, we do the hole, we stop. Now we need to have osteoblast and mineralization. Okay? So the resorption phase is followed by invasion of pre-osteoblast into the base of the resorption cavity. These cells become osteoblast and they make the bone matrix. They stop this whole process لما يوصل الثickness 20 microliter. 20 micrometer. Oh, sorry. So it's a 20 micrometer where they stop. But this whole process is a lengthy process. And where is the issue? Tell me, how do I get osteoporosis? I want to know now. Basically, every cycle, this is a cycle of bone remodeling. Every time, بيصير في some imperfections. It's not a perfect process. Something is missing. فبيصير accumulation of these imperfections, and by age, we reach a point that we have osteoporosis. It's called age-related bone loss. So small bone deficits persist on completion of each cycle, reflecting inefficient remodeling. Okay? And look here. We have this graph that shows female versus male. أول شيء, what can you tell? Tell me the difference. First of all, what can you tell me the difference between male bone density and female bone density?
Higher.
So initially, we talk about a higher bone density in male. Let's put this one. Okay? What else? Age. What about age? Around the same age, we see the peak, I think. We're talking about 30, 35 years old. When it goes down, after menopause, the peak is higher. The slope is sharper. And it's not, مش زي المale, look, very slow and easy. But here it's a sharper loss. Okay? That's why female are more prone for osteoporosis more than male. That's why they look for medications that are tailored for females. صح؟ طيب, tell me, what are the factors that are affecting the maintenance of bone homeostasis? Go.
So the loss of the bone mass in female is less than the loss in male.
Because
But after the menopause, it's sharper. It becomes sharp. But at the end, it's
Right. But give me factors in general that will affect incidence of osteoporosis. What? Estrogen. Okay, what else? Contraceptives, ايش فيها؟ Corticosteroids, that drug induced, yes. What else? Vitamin D. Calcium. What else? Huh? حكينا. Corticosteroid, we said it, drug induced. What else? Huh? No, don't whisper. Parathyroid hormone, what does it do?
Osteoporosis.
Calcium absorption. So it helps in osteoporosis, parathyroid.
Yes.
Yes.
What's the role of parathyroid?
Bone resorption to increase calcium in the blood.
Okay, so it increases the calcium in the
Blood by resorbing the bone.
Okay, so it will lead to osteoporosis ولا
Yes.
Yes.
So it can add to the if I have a lot of stimulation of لنقول عندنا benign tumor وفي عندنا parathyroid hormone elevated معناته risk of osteoporosis high ولا low؟
High.
What else؟ بس هاي حطوا عليها big question mark لأنه هلا I will tell you give you a big surprise. What else؟ postmenopausal age؟ ما ما ادري شو السؤال. Factors factors affecting the maintenance of bone homeostasis.
ايوه اوكي صح postmenopausal
إنه ما
Estrogen.
estrogen goes down.
Yes, but someone said it.
إذا
But okay, لأنه قلت yeah. Daydream. You're the girl who daydreams, right? You're my friend. I always daydream. Huh? What else? Another hormone. يلا سيروني. Calcitonin. أنتوا طلعتوا على slides. Okay, thank you for the effort. Calcitonin. Thyroid. بس calcitonin, what does it do? Calcitonin is part of the thyroid gland.
It's part of the calcium deposition.
No, this is your game.
Give me a scenario where calcitonin is released. Hypercalcemia. Now what? Hypercalcemia.
It deposits
Yeah, so compensation.
Okay, so it's the opposite of parathyroid hormone. Okay, good for a medication for postmenopausal. Right? Makes sense. Why? It will increase the deposition of calcium in the bone. Right? It's a
Like,
good.
what about the blood? Does it cause hypocalcemia in the blood?
If you stimulate ما هي نحن عم نحكي physiologically. Okay? Yes. If you give it pharmacologically, if I give something miacalcic, it's called calcitonin, they extract it from the salmon, it's called miacalcic. If it's not taken properly, then maybe it will cause hypocalcemia, the other side of midnight, right? Right. Okay. Yes.
And I heard information and when we give like calcium supplement,
Huh.
the absorption for the calcium from the organs is just like if we give 20 ولا الابsorption بس تكون 1% يعني لما 1
Okay, and why is there vitamin D? Do you know how? How?
It's what it
How? يعني احنا عندنا فيتامين دي والريسبتور تبع فيتامين دي ريسبتور VDR. Okay, if they bind, it's like a steroid, right? Vitamin D. So it produces what? Increase the expression of what? Transporters that take the calcium back to the body. Transporters. Let's go from the food, from the side of the digestion to the side of the circulation. Increases the transporter expression. If there is low vitamin D, yes, the calcium absorption will be much lower, definitely. Hala, what about estrogen? We always say estrogen. What does estrogen do here?
The osteoclast.
Like calcitonin.
Look, it's here. I just, there's an X there. ذكرتوا osteoprotegrin. What does osteoprotegrin do? Inhibit the rank L. And if it inhibits the rank L, it will stop the osteoclastic activity. Now, what if it's blocked? What if osteoprotegrin is blocked? What happens? The osteoclastic activity will keep on going. And this happens when we have what? Estrogen deprivation. Okay? This is what happens when we have estrogen deprivation. Now, again, parathyroid hormone, it increases the calcium reabsorption, but at the same time increase osteoclastic activity. And calcitonin inhibits osteoclastic activity, and that's why it's one of the drugs that we will be using for today. Type. Drug-induced. So what do you think of the glucocorticoids? What does glucocorticoids do to an osteoporotic bone? Or how does it increase osteoporosis? Huh? Stimulate osteoclastic activity through what? So, كمان it will inhibit osteoprotection. كمان it will inhibit osteoprotection. كمان الglucocorticoids, please remember that it does decrease or inhibit luteinizing hormone and follicle stimulating hormone. And as a result, the estrogen levels will be low, so that will help also in increase the chance of osteoporosis. There is more. It will increase osteoblast apoptosis. It will, increase osteoblast apoptosis. معناته the building cells are dying. We're eating them, we're killing them. It will decrease the development of osteoblast. And as I said, osteoprotection is decreased to sex hormone is decreased. I think here we are done pharmacology. We're starting pharmacology. Two types of drugs, two groups of drugs. Anti-resorptive and anabolic. When I say anti-resorptive, what do I mean?
Inhibiting osteoclast.
They will inhibit osteoclastic activity. خلاص, anti-resorptive, they go, whatever, whenever you read in the exam, anti-resorptive, the mechanism has to be decrease osteoclastic activity. In what manner, doesn't matter. Thus, it will decrease osteoclastic. What about anabolic? The site of action is what? Increase what? Osteoblastic activity. That's it. And what's more popular is the anti-resorptive. What's taking the main share of the market in terms of treatment of osteoporosis, let me tell you, we're in the anti-resorptive drugs. Okay? Mainly something called bisphosphonates. Bisphosphonate. Do you know any example of bisphosphonate? Huh? Okay. It's the dronate. Remember, dronate, when you memorize the drugs, dronate is always there. But alendronate, risidronate, zolindronate. السلام عليكم. تحتاج شيء؟ ها؟ Garbage? Thank you so much, dear. Okay, so bisphosphonate has another name called calcium metabolism modifiers. Calcium metabolism modifiers. Just to let you know, in three generations. The old generation, etidronate, we're not going to be talking about it a lot because we don't use it a lot. The second and third are more important. Okay, هلا we're going to say how are these modified. The second group of drugs سموهم SERM, from the name. مش قلنا عاد يعمل في estrogen, the effect of estrogen. Okay, so SERM is a selective estrogen modulators, selective estrogen receptor modulators. From the name, what do you think? The mechanism. But Anna, why I don't give estrogen? Now give me, so خلص, it's very easy. I have the contraceptive, very cheap. I go to the pharmacy, give me HRT and I'll take it. Because we are worried about the risk of cancer that is related to the estrogen. Now what did they do here?
Some they stimulate the endogenous estrogen.
You're activating the receptor.
Selective. خلي keep the idea in mind. Huh? The third drug هو الكالسيتونين. Calcitonin we talked about. خلاص done. Inhibit osteoclastic activity. It is an endogenous hormone, but they make it into a drug, بسموها مية calcic, extracted from the salmon. Okay. The last drug اسمه denosumab أو denosumab اللي اسمه دينا يحكي اليوم. Anyone Dina here? Dino? No? Okay, so denosumab is a monoclonal antibody. Look, what does it attack? Monoclonal antibody, يعني protein, comes and stops a certain protein. This protein here, rank N. Remember the ligand that's coming out of the osteoblast? The denosumab comes and attacks it and says we can't work anymore, which gives me the chance not to activate osteoclastic activity. Please stay, you don't need to be active anymore. I don't want to lose more bones. Stop it. Questions?
يعني
إيش إيش؟
السر في كلمة ماب إنه أبان بالبروتين.
الدينوسوماب is a monoclonal antibody. Denosumab is a rank L inhibitor. Remember rank L? احنا قلنا في receptor اسمه rank. في ligand that binds to rank, otherwise no activity for the rank. The ligand itself, which is out of the osteoblast, coming from the osteoblast to the osteoclast, is attacked by denosumab. No? Yes? Repeat. Repeat or repeat? Repeat. Repeat? No? Repeat? Repeat. Okay. So these are how many examples of anti-resorptive drugs? 4. Anabolic drug, أنا بدي أعطيكم there's more than one. I'm giving you one. طب read. مين who's gonna read? I want someone in the back. My lovely green covered girl at the back. Can you read what is teriparatide?
Parathyroid is a form of parathyroid hormone consisting of the first 34 amino acids.
So what did we talk about parathyroid? What did we say?
Stimulate.
معقول? They made a mistake?
لا بس
How are they giving us a drug that increases resorption?
Maybe
Yeah, they
because
mistake. I think
the
we're going home.
feedback.
حياة الله خلاص. طب كيف؟ ما عم نحكي إنه we give it in cases of hypocalcemia and we want to replenish the calcium stores in the blood and we take from the bone, please bring us more calcium to the blood. When we lose the matrix, mineralization, we get osteoporosis. How come they're telling us anabolic?
يمكن عشان يعيد البروسيس تصير. It's not for all.
Maybe because
Maybe you're taking only the vitamins you.
Hold your idea. Hold your idea. بس كثير أنا زعلانة منه. I'm really upset. يعني they're cheating us.
Maybe
no,
That's
maybe
outside.
because the
Huh?
feedback.
maybe we're trying to get the negative feedback to work.
Huh?
Maybe it's fine.
Maybe. They want a drug that doesn't do anything. It's binding.
لا هو صح
Okay. So another thing is supplements, calcium and vitamin D. Let's start with bisphosphonates. Bisphosphonates. طيب. Bisphosphonates هن drugs that are similar in structure to something called inorganic pyrophosphate. طب ليه عم بحكي inorganic وحولنا chemistry way? Because these, look, there's a 2-phosphate group and linked to an ester, and that's it. That's the inorganic pyrophosphate. They modified it instead of ester, حطوا carbon in between, okay? And they attached 2 R's, R1 and R2. That attachment turns the bisphosphonate into 1st generation, 2nd generation, and 3rd generation. It's just to change the R's, okay? So, the only difference, مثل ما مكتوب, there's an oxygen, instead of that there's a carbon, okay? هلا, different, bisphosphonate differ in the side chain. Fine, طيب, what do I do now? Now, they basically like, the pyrophosphate on its own like to bind to calcium, whenever there's calcium. And where is the main source of calcium? The bones. So it's their safe haven. Bisphosphonate like to stay there, okay? Keep that idea, okay? Now, this is done, it's an anti-resorptive. They are basically, they bind to mineralized bone surfaces and they are taken up by the osteoclast. So هي البisphosphonate وهي الاوستيوكلاست, they're taken by the osteoclast during bone resorption. هلا هنا خدوا نفس. Ready? Drugs. Okay. The first generation, it's called etidronate. Example, etidronate. The only thing I'm going to tell you that R1 and R2 doesn't have any amine group. While 2nd and 3rd, they have an amine group. And that amine group added a new mechanism of action. That's why I'm talking chemistry today. Okay? So second generation and third, yani when I talk alendronate, residronate, zolendronate, ibandronate, pamidronate, they are all, in their R, there is an amine group. Okay? Hala. The potency increases as you go from the first generation to the third generation. Okay? The potency. It's more potent. Now, in simple words, but I can't make life simple, sorry for you today. I can't afford it. I have to explain. It's basically binding the bisphosphonate, decrease bone resorption, decrease progression of osteoporosis. That's the take-home message. And why do we use it? We use it for treatment and prophylaxis for osteoporosis. حتى in male. فشوفوا the advantage of bisphosphonates. You can give it for male and female. You can give it for people with glucocorticoid-induced osteoporosis, and you can give it for postmenopausal osteoporosis. Good? Not bad, huh? It's a good offer. طيب, what is the contraindication? هلا, the contraindication, unfortunately, okay, these drugs very badly absorbed, very low absorption, 1%, I don't know, okay, very low absorption. And you need, in order to maximize the absorption, you need to do the following. Here we go. You wake up in the morning early, and you have to drink a cup of water. You have to stay in the upright position for half hour to 1 hour, just to maximize the absorption. تخيل مش واقفة قاعدة بس upright position مش هيك. هلا نحن مثلا we would wake up in the morning, take the pill, right? We do that, or that we can't. With bisphosphonates we can't. Okay? هلا what is good about this too, إنه it is really binding to the bones, and it has this long effect, so it stays in the body for the longest time, remember? So actually bisphosphonate is one of the group of drugs introduced this dose breaks. يعني تخيلوا bisphosphonate, alendronate مثلا, you give it once weekly. Can you believe it? مرة واحدة بالأسبوع. تصحي الصبح توقفي, cup of water, upright position, done, next week. طب I'll give you more. Ready? Zolendronate, اللي هو third generation, you give it, where's zolendronate? Zolendronate, هي. Once a year.
Wow.
Once a year. Once a year stays, you give it as an injection, stays once a year, that's it, and it treats severe osteoporosis. So this is a very important concept. We were not used to it. نحن we are used to a drug every day, drug every 8 hours, but no, with bisphosphonates, the things are different. Why I'm telling you I'm bisphosphonates? And I used to work on alendronate. So alendronate, initially it was 10 milligram per day, and a patient had to wake up every day to take the medicine. Then 2-3 years down the line, they started giving it once a week. So we started saying, listen, it's worth it, we have to take it once a week. And really, they have a lot of studies about fracture reduction, so there has a very high efficacy regarding osteoporosis. Okay? I'm promoted for alendronate. Okay, so why I'm saying all of this? Because the contraindications is someone who cannot sit upright for at least 30 minutes. Contraindicated. شو بعمل؟ بعطيه parenteral. I would give him a parenteral drug. اللي هو نفسه zolendronate is parenteral.
هي تقولي مثال انه واحد ما يقدر يقول، مثلا واحد في السرير او واحد سوى عمليه.
طبعا. bedridden people. في كثير ناس bedridden. They can't stay. Yes. So definitely, there's a lot of people who cannot take this drug. People with hypocalcemia, لأنه this will lead to hypocalcemia, so this will make things severe hypocalcemia, okay? People who have issues with the esophagus because it does irritation. So people with the stricture, achalasia is another name, واللي هي في عنا deformity بالesophagus, you can't swallow it. Then you move to the parenteral form. Zoledronate can be given parenteral, ibandronate can be given parenteral, so on and so forth. هلا هون ready because this is really really challenging. You want to leave, I give you the option. No, I can't take the responsibility that I moved. Ready to, you want to stay? By the way, we're done. If you want to leave, it's okay. You want to stay? والله. ها؟ بس are you ready to hear this? No. بسم الله. Okay, so again, I am talking about second and third generation. First generation has a different mechanism. We don't use first generation anymore, خلاص. Basically in the market, second and third. The second and third, we said, what is the difference? The R group has an amine side chain. And if the amine group in the side chain, خلاص, easy. Now, because of that, the mechanism is involving the mevalonate pathway. Do you remember mevalonate pathway? Yes, Sheikh. Cardiovascular CVS block, mevalonate pathway. Statins. شوفوا statins أيوة أحمر. قاعد الستاتنز هون في الشيء. التنجيكو إيريدكتيز.
بس الموفيلينيت
يا شيخة.
موفيلستاتين.
من والله لا. حجيب مسبح المرة. وضع صعب. Okay? So this is the pathway where cholesterol is formed and can be inhibited by statins. Let's put this information on one side. There is two enzymes that is inhibited by bisphosphonate. Let me tell you what are they. It's called farnesyl diphosphate synthase. Farnesyl diphosphate synthase. This enzyme, okay, inhibits a process in the osteoclast. خلاص احنا in the osteoclast population of cells called prenylation. Together, 1 2 3. Prenylation.
Prenylation.
Again.
Prenylation.
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 طب what is prenylation? اللي عم تحكوا prenylation. ها? Okay, this is a very important concept. نحن when we produce proteins بالnucleus. طب how do we know that this protein that's formed is going to go as a channel expressed on the surface? I was going to go in the mitochondria or stay in the nucleus. I will stay in the targeting. Targeting. There are certain products that are coming from here that are responsible for prenylation. Prenylation bye. It's okay, perfect. مأساة. جاي عندي؟ بدك تروحي؟ تحكي تليفون؟ On the phone? No? Mom? Say hi to her. Mom. Okay, شايفة بنتها من الصبح. تحكي لها مرحبا. Okay, so prenylation is basically, this pathway is responsible to produce proteins that are responsible to do prenylation. Prenylation is any protein produced. These byproducts coming from this pathway, they bind to them and they target them to different areas of the cell. يعني تخيل إنه نحن في طابة كبيرة والنيوكليوس بالنص. They're producing a lot of proteins. This is continuous. Prenylation is these sequences or proteins that bind to any protein coming out, targets it either to the surface, to the membrane, to the nucleus, to the cytoplasm, to the mitochondria, prenylation. And this is blocked by bisphosphonates. Okay? If the bisphosphonate is blocked, معناته if I have an osteoclast and this osteoclast needs receptors, these receptors are not targeted. ما في شيء على السيرفس خلاص done. These receptors are not in the proteins are not in the right place. That led to basically reducing the cell, and this will eventually lead to apoptosis of the osteoclast. So bisphosphonate will lead to apoptosis through inhibiting what we call prenylation. مين يحكي لي prenylation؟ لا. The prenylation هي a process where you attach stimulation.
يعني
Directed.
بروتين اضيف عليه
أيوة.
اقول له روح هنا.
بالضبط.
طب ايش البروتين اللي احنا
البروتين any protein يعني نحن calcium channels. خليني اقول لك I'll give you a simple example. Calcium channels is produced. Calcium channel is made of more than one subunit, alpha وبيتا وغاما. هلا it is thought that beta is responsible for targeting of the channel to the membrane. يعني once this is produced, binds to the channel and takes it like a taxi. تخيلوا taxi. Oh, I know you're going to this hotel. You're going to this area. You're going to this house. This is prenylation. Okay? So if this pathway, which is in so many cell types, it's in all cell types, okay? But in the osteoclastic activity, the bisphosphonate is likely to bind and inhibit the prenylation, and as a result, the proteins in the osteoclastic cell is not properly targeted. It's not properly directed to the membrane, to the nucleus, to the cytoplasm. What does that give me? Basically a very sloppy cell. Nothing, I'm good for nothing. If there is no channel expressed, I'm good to do anything, right? So that's why osteoclastic activity is killed indirectly through the bisphosphonate. خلاص؟ هلا شوفوا يجي سؤالي طب دكتور if I give statins will I improve osteoporosis?
Yes.
Okay, so احنا قلنا by the way guys this mevalonate pathway is not for one type of cell, it's for cells, so many types of cells فيها الميفالونيت pathway. معلش الساعة 5 أي شيء يصير اليوم
هي الكوليسترول ولا
ميفالونيك اسيد السكند
اللي هي الميفالونيت pathway is this pathway
كوإيركتيف
which eventually produces cholesterol.
ميفالونيك
That's the pathway. Okay? So the statins, what about the statins? معناته can we say that? Can we say everyone who's taking simvastatin will improve his osteoporosis? Actually, not really. Why? Because the statins don't get into osteoclastic. Cannot get to osteoclastic. خلاص? That's why some studies are sporadic here and there, but we don't have something really substantial. امشي ولا تستعنا كل الادويه الثانيه؟ شوفوا قديش خلصنا الوقت بدنا نروح. يلا. So overall effect of bisphosphonate, it reduced osteoclastic activity, decreased osteoclast progenital development, recruitment, and promoting osteoclastic apoptosis. Okay? That's the overall. الادverse effects. Listen. بما انه عم نحكي عن a drug that is really toxic for the esophagus. So esophagitis is one of the GI toxicities. Esophageal irritation, heartburn, abdominal pain, diarrhea. So we think GI when we think of bisphosphonate. Rarely something called osteonecrosis of jaw. For some reason, this is asked a lot in the USMLE exams. Osteonecrosis of jaw. It's a rare complication when you give bisphosphonate, high doses, long term. High doses for a long term. Okay? And flu-like reactions. This is another adverse effect. So look, this is how it looks, osteonecrosis of jaw. So it's nasty. Time. Yeah, doctor. Osteonecrosis is a rare adverse effect. This is how osteonecrosis, the dentist, you have to follow up with the dentist when you take bisphosphonate for a long time because it will lead to necrosis in the gum and the bone, and it's a very rare adverse effect. Mechanistically, I can't explain it, but they found it in people who take bisphosphonate for high doses long term, cancer patients. Okay? Type estrogens. Estrogens, we know that estrogen, what is the mechanism? We talked about it. It inhibits what? If there's estrogen deprivation, OPG, which is osteoprotective. If we have estrogen deprivation, معناته we have low osteoprotegrin. Osteoprotegrin is inhibited. Okay. Bismillah. Hala, let's see here. What do we mean by SERM?
selective estrogen
Osteoprotegrin osteoprotegrin is inhibited. ليش؟ It will lead to rank L deprivation. Estrogen deprivation will decrease the activity of osteoprotegrin. عكس. إذا عندي estrogen الاوستيوبروتاجرين بيكون شغال and inhibits rank L. بس إذا عندي estrogen deprivation معناته osteoprotegrin will not be released and as a result rank L will increase and activate more osteoclastic cells. خلاص؟ طيب. The second drug اسمه selective estrogen receptor modulator. تحولنا كرتون وليجو هلا. This is the estradiol. This is estradiol. And this is the estrogen receptor. Remember, في two populations of receptors بالestrogen. And it varies from one tissue and tissue population over another. And the last is our drug, which is raloxifene. What's the difference between estrogen and raloxifene? Look. This is the estrogen receptor. Usually, what do we have now? Usually, it's an intracellular receptor. It increases genetic activation. ففي عندي differential expression of multiple estrogen regulated genes in different tissues. Now, if I bind the estrogen to its receptor, it will activate the breast and uterus along with the bone mineralization and activity will decrease the risk of osteoporosis. But now we're worried about the breast and uterus, right? We will increase the risk of what? Of cancer. So what does the raloxifene do? So this is the raloxifene here on this arm اللي هي بتعمل activity على osteoclast, decrease the resorption activity of osteoclast. What does it do? Produce estrogen-like effect on the bone. صح؟ But on the other hand, it antagonizes the effect of estrogen on the breast tissue and uterus. So this is a good scenario, right? Okay. What are the adverse effects? احنا قلنا انه receptors are expressed in different combinations in different tissues. It's good on the bone, but in the breast and uterus it is we are protecting that patient through raloxifene. However, it might increase deep vein thrombosis لأنه estrogen affects the coagulation factors or increase hot flushes. Okay, so you see hot flushes and venous thromboembolic events are increased. Another drug اللي هو calcitonin. From now on, everything is a revision. Calcitonin, it's a hormone. We know it acts on inhibiting the osteoclastic activity to decrease bone resorption. Okay, done. Denosumab, remember denosumab? That's it. This is the picture. This is the monoclonal antibody. Goes for rank L, binds it, inhibits it from binding to the receptor. Easy? But why would I give denosumab? With severe cases, severe osteoporosis. We don't give it to any postmenopausal woman with osteoporosis. We give it with, for example, a male with androgen deprivation. Okay, we give him that. A lady who has breast cancer, yes, we give her that. Okay? Most common is hypocalcemia, hypersensitivity reactions. Okay? There's a high risk of infection for those patients. This is because this ligand is also expressed on immunological cells, which makes it more efficient, more active. Having it absent will affect the cell maturation of dendritic cells. Anabolic drugs, one example, teriparatide. So back to our teriparatide. Remember, قلنا parathyroid hormone treats people with hypocalcemia in the blood, they resorb bone, and still I'm giving it as an anabolic drug for treatment of osteoporosis. So what's the key word? Why? How?
recombinant form. Recombinant form. Recombinant form.
Fine, but it's still a hormone. It does the same thing.
Maybe it activates the negative
Dosing.
Parathyroid.
Because of dosing. Okay? If I give a high dose, continuous dose of parathyroid hormone, if the parathyroid hormone is stimulated continuously, the activity will be on increasing osteoclastic activity and increasing bone resorption. If you give teriparatide, which is the case, they give it subcutaneously once a day, okay? They give it intermittently, it's not continuous, it's just subcutaneous done, and in small doses, this is what's making the effect go on the osteoblast activity and increase the osteoblast activity. Right?
Yes.
Yeah. هلا, you say these are the same medication, the same hormone, بس نحن we played around with the dosing and the way we give it. If you give parathyroid hormone on a continuous infusion, let's say, parathyroid hormone will act on activating the osteoclastic activity, increasing bone resorption, increasing osteoporosis. The teriparatide, it's called an anabolic drug. Why? Because we played with the dose. We gave a lower dose and we gave it intermittently. We gave the dose, خلاص. Then another day we give the subcutaneous injection. That's how the activity is on maturing more osteoblast, increasing the osteoblastic activity. Okay? So let's see. One last slide وخلاص. So recombinant form of parathyroid hormone. Look here. This is the chronic use of parathyroid hormone. شايفين the chronic, the word chronic up. This will lead to what? Chronically elevated parathyroid hormone will deplete bone stores. But if I give it intermittently, مثل الteriparatide, if I give it intermittently in low doses, it will activate osteoblast more than osteoclast. So this is how they fixed it. Okay?
Doctor, even in our body, when we
نحن ما عنا احنا physiologically it depends even in our body, but it depends نحن what is needed. If we have hypocalcemia, parathyroid hormone has to increase the activity of osteoclast. Okay? But they found out that it depends on the fluctuation of the hormone. This if it's intermittent, then the osteoblastic activity will increase more than the osteoclastic activity.
is there
Even in our body. And how did we find out this? We found out through studies on animals. They tried to measure the dose, decrease, suppress parathyroid hormone, remove the glands. They were playing around to find out this theory, it works.
So it's even better than the
Continuous parathyroid stimulation.
لا انه low dose is better than no dose at all. Like the absence of PTH,
ما هي PTH ما في
we can't consider.
في عندنا at least baseline secretion definitely. Okay? So
So PTH is different than what
it's احنا we took the first 34 amino acid, which is the active hormone. We manufactured it, we give it to patients. It is PTH, but it's not the whole length of amino acid.
if the patient does not have PTH and have chronic disease or something
not have
else lead to osteoporosis, can we give him PTH but it's intermittent?
Yes, we can give PTH, but then you need to know the cyclical release of the hormone. You have to imitate the body. How does it release it? Which is not easy. But yes, definitely. Okay? So to whom do we give it? Patients with severe osteoporosis, and adverse effect is nausea, leg cramps, and dizziness. This is the non-pharmacological management of osteoporosis. Stop the drinking, stop smoking, counseling on fall, and take vitamin D and calcium. This is a good review for you when you go back home. Okay, so what do you think? Yalla. What is the drug of choice for management of adrenal glucocorticoid-induced osteoporosis? From the list, what do you think? A. Well, actually, you're right. A is the right answer. هلا calcitonin is good, but efficacy-wise, calcitonin is less effective than the bisphosphonates. So definitely, this is the drug of choice. يعطيكم العافيه.
Thank you.
Thank you.